This video examines the current research on child and adolescent suicide, covering epidemiology, risk factors, and treatment approaches. I will explore how suicidal behavior increases dramatically during adolescence, review the key emotional, behavioral, and cognitive factors that elevate risk, and discuss what we know about effective interventions. The content is based on comprehensive research reviews and clinical studies, providing an evidence-based foundation for understanding this critical public health issue. My goal with this video is to present the science clearly while emphasizing prevention opportunities and treatment implications for clinicians, researchers, and those working with adolescents, as well as for you, dear viewers, who don't fit any of the categories. Adolescent suicide represents one of our most pressing public health challenges. Suicidal behavior increases in frequency as children transition from pre-adolescence through adolescence, with rates continuing to climb into young adulthood. This presentation will systematically review the current evidence on prevalence rates, the major emotional, behavioral, and cognitive risk factors that predict suicidal behavior, and what research tells us about effective treatment approaches. The statistics on adolescent suicide completion reveals the severity of this problem. Suicide is the second leading cause of death for ages 15 to 24 in the United States, with incidence rates rising dramatically through the late teenage years. The primary methods, firearm accounting for nearly 50% of deaths, followed by suffocation at 38% and poisoning at 7%, highlight how access to lethal means directly impact mortality. Historically, trends show a peak in 1990s, now followed by a decline in the 20s, though the causes of these changes remain unclear. Some researchers point to increased antidepressant use in suicide prevention programs, but the picture is complex. Understanding these patterns is crucial because method availability represents one of our most actionable prevention targets through means restriction approaches. Population-based surveys reveal that suicidal thoughts and behaviors affect a substantial number of adolescents each year. According to a 2007, a bit old, youth risk behavior surveillance data, 14.5% of teenagers seriously consider attempting suicide, and 11.3% of youth develop a suicide plan. Perhaps most concerning, 6.9% of teenagers attempt suicide one or more times annually, with 2% making attempts serious enough to require medical treatment. These figures demonstrate that suicide ideation and attempts are not rare events among adolescents, but rather common experiences that require systematic screening and response. The gap between ideation attempts also suggests important intervention opportunities during the planning phase before behaviors escalate to actual attempts. Demographic patterns on adolescent suicide reveal important disparities that must inform prevention efforts. Male adolescents show much higher suicide death rates, 16.8 per 100,000 population, compared to 3.6 females in 2004. While females report higher rates of suicide ideation and non-fatal attempts, this pattern largely reflects differences in method choice and lethality, as well as the varying profiles of comorbid risk factors. Racial and ethnic differences are also pronounced. Native American youth show the highest rates, while recent data indicate concerning increases among African American males and elevated attempts among Hispanic adolescents, particularly females. Age patterns show suicide rates rising after puberty, peaking in late adolescence and early adulthood, emphasizing the developmental timing of risk. One of the most robust findings in suicide research is that prior attempts strongly predict future suicidal behavior. A prior suicide attempt is the single most significant factor for youth suicide in both case control and prospective studies, increasing the risk of subsequent completion by 10 to 60-fold. The risk for repetition is the highest in the first 3 to 6 months after an attempt, but it remains substantially elevated for at least 2 years. Among adolescent attempters, rates of subsequent completed suicide range from 0.5 to 1% per year, rates considerably higher than the general population. These findings have critical implications for clinical practice, the need for intensive monitoring and follow-up care immediately after any suicide attempt, with particularly attention to safety and crisis intervention supports. Behavioral risk factors provide observable warning signs that can guide clinicians' assessment and intervention. Self-harm without suicidal intent, referred to as non-suicidal self-injury or NSSI, is associated with adolescent suicidal behavior and is highly prevalent among suicide attempters. Research suggests that 70% of psychiatrically hospitalized adolescents with NSSI history also report suicide attempts, with multiple self-injury episodes predicting particularly high risk impulsivity. Impulsivity and aggressive behaviors are also strongly linked to adolescent suicide, though findings vary by population and measurement approaches. Substance abuse disorder creates a 3 to 6-fold risk increase in suicide attempts, particularly when combined with other mental health conditions. Disruptive behavioral disorders like conduct disorder increases risk, especially in combination with mood disorders, reflecting the dangerous interaction between externalizing and internalizing symptoms. Cognitive factors represent potentially modifiable targets for suicide prevention interventions. Hopelessness is a cognitive state that often accompanies depression and is reported by many adolescents who attempt suicide, including lowered expectations for achieving goals and anticipation of negative future outcomes. While hopelessness predicts suicidal ideation, its predictive power can be attenuated when controlling for depression, suggesting it may be most relevant during acute depressive episodes. Problem-solving deficits are also linked to suicidal behavior, as many adolescents view suicide as a solution to seemingly unsolvable problems. Research shows that 68% of adolescent attempters expected their attempts would positively influence their problems, while 38% reported being unable to think of alternative solutions. Importantly, confidence in problem-solving ability and strong survival and coping belief serve as protective factors, highlighting the importance of building these cognitive resources. Family factors operate through multiple pathways to influence adolescent suicide risk. Results from adoption twin and family studies all provide evidence to suggest that suicidal behavior is transmitted from parent to child through both genetic mechanisms and environmental factors like parental psychopathology and family dysfunction. Intermediate phenotypes such as impulsive aggression appears to mediate some of these transmissions. Family environment characteristics, particularly low cohesion, high conflict, and unsatisfying parent-adolescent relationships, are more frequently observed in families of suicidal adolescents. Childhood physical and sexual abuse represent particularly robust predictors of later suicidal thoughts and behaviors, often interacting with other risk factors to create cumulative risk. The relationship between abuse and suicidality may be mediated through effects on impulsivity, aggression, and neurobiological development, emphasizing the need for trauma-informed assessment and intervention approaches. Environmental factors highlight both risk sources and intervention opportunities in adolescent suicide prevention. The media also has a significant influence on suicidal behavior among adolescents and adults alike. The results are more consistent in studies that examine the effect of non-fictional descriptions of suicide, exposure to peer suicide through clusters, media reports, or direct contact can increase risk through social learning and contagion effects, with emotional closeness and temporal proximity to the suicidal model modulating the relationship. Stressful life events and trauma exposure also elevate the risk for suicide planning and attempts. Perhaps the most concerning are the substantial gaps in post-attempt care. Many community treatment studies show that adolescent attempters receive limited outpatient follow-up with high dropout rates and brief treatment courses. While community clinicians increasingly report using cognitive behavioral techniques, engagement remains a persistent challenge that limits treatment effectiveness. Individual therapy research with adolescent suicide attempters show mixed but promising results across several approaches. 3 individual therapy trials have been reported, each offering important insights. The investigators concluded that the SBT protocol used in this study was worth further investigating, particularly with further investigation and modification to increase session frequency in the first critical month after an attempt. Dialectical behavioral therapy shows some advantages over usual care, including fewer hospitalization and higher treatment rates. However, the most rigorous randomized trial comparing skills-based cognitive behavioral treatment to supportive relationship therapy found that both approaches produced significant improvements in suicidal ideation and depression with no between-group differences. This suggests that therapeutic engagement and alliance may be as important as specific techniques, though the field needs larger studies with longer follow-ups to draw firmer conclusions about optimal individual therapy approaches. Family-based interventions recognize that adolescent suicide occurs within family systems that may both contribute to risk and serve as resources for recovery. The additional home-based family intervention resulted in reduced suicidal ideation at 6-month follow-up compared to routine care, but only for adolescents without major depression, suggesting that family approaches may be most effective for certain subgroups. The SNAP program is 6-session outpatient treatment for female minority attempters, successfully reduced overall symptom levels by teaching negotiation skills, affect management, and problem solving through role-playing and modeling. Family interventions typically focus on improving outcomes and communication patterns, enhancing problem-solving skills, and providing psychoeducation about adolescent development and suicide risk. However, engagement can be a major barrier as family therapy shows lower attendance rates than individual or medication management approaches, requiring creative strategies to maximize participation. Group therapy approaches have been both promising and concerning results that highlight the complexity of treating suicidal adolescents. The Wood et al. Study was the first study to demonstrate a reduction in repeated suicide attempts within their group intervention, producing significantly fewer multiple reattempts compared to routine care alone. However, an Australian replication study found contradictory results, including higher rates of suicidal behavior in the experimental group at 6-month follow-up. This pattern suggests that group formats may help some populations while potentially carrying a risk for others, possibly through social contagion effects or inappropriate modeling. The intervention combined cognitive behavioral and dialectical behavioral therapy techniques within both active focus sessions and longer-term process groups. The mixed replication results emphasize the need for careful monitoring of group interventions and suggest that group composition, leadership, and content may be critical factors in determining whether such interventions help or potentially harm participants. Intensive multi-module treatment programs attempt to address the complexity of adolescent suicide through comprehensive approaches. At 1-year follow-up, the MST group had significantly lower rates of suicide attempts than the hospitalized adolescents, representing one of the strongest treatment effects found in the literature. Multi-systemic therapy's home-based family-focused approach that addresses multiple ecological systems appears particularly promising. In contrast, the comparisons between different inpatient approaches such as DBT-informed units versus traditional psychodynamic units have shown that both intensive approaches can reduce suicidal ideation and behavior, but without clear superiority of one model over another. Day treatment programs have produced improvements comparable to community care for many patients, though those with more complex comorbid presentations may benefit from intensive structured interventions. These findings suggest that treatment intensity and ecological scope may be more important than specific theoretical orientations. Adjunctive interventions aim to enhance standard care by providing additional support during those high-risk post-discharge period when compared to standard care. The interventions resulted in a decrease in suicidal ideation at follow-up for girls but not for boys, illustrating how gender may moderate treatment response. Social network interventions that engage youth-nominated support persons in maintaining regular contact show promise for reducing suicidal ideation but have not demonstrated clearer effects on actual reattempt rates. These programs recognize that the transition from intensive care back to community settings represents a vulnerable period when many adolescents lose connection with services and supports. The differential effects by gender suggest the suggests that boys and girls may benefit from different types of social support interventions. While these adjunctive approaches may not be directly prevent attempts, their effects on suicide ideation and overall mental health may contribute to longer-term recovery processes. The treatment outcome literature on suicide attempters is quite small, pointing to critical gaps that future research must address. Expanding our efforts will require longitudinal studies that can disentangle the complex interactions among genetically vulnerabilities, neurobiological factors, neuropersonality traits like impulsive aggression, and family environmental influences. Measurement provide precision and represents another priority, with a shift toward dimensional assessments of traits and behaviors rather than relying on categorical psychiatric diagnosis. Treatment research needs innovative design that can accommodate the realities of treating high-risk populations, including combined interventions, intensive early dosing in the first post attempt, and flexible booster sessions over extended follow-up periods. Perhaps most importantly, keeping high-risk adolescents engaged in research protocols rather than removing them when they experience clinical deterioration will be essential for generating findings that generalize to community practice settings and ultimately inform more effective interventions. Thank you for watching this video and trying to understand the associated factors of suicide and non-suicidal self-injury among children and adolescents. While the factors are very much diverse, I hope I was able to provide a glimpse into why these incidents happen so often and why is it common among my age to attempt or die by suicide or experience suicidal thoughts. Thank you very much for your time, and I'll see you next time.